Second case, another very exciting one, and this one we get a little more view of what it actually looks like in the surgery center. That first view is the patient at the actual femtosecond laser with the docking, where the actual first channel is being created.
And again, this fixation light with IMAX makes sure that the implant is centered on close to the visual axis of the patient.
That is the same laser being used to create something like a LASIK flap, and now can be utilized for this CAIRS procedure. So in this same example, now we're seeing the surgeon's view. So this is inferior cornea where that actual tissue is being placed, but in our view, it's at the top of our screen. But that is going to correspond with the inferior cornea right there. And we can see as that tissue slides right in, kind of like when I stuff my stockings before Christmas.
And also, sorry for the focus, but you can see that this is a much smoother approach already than my first case. I didn't use sutures anymore in this one, and the tissue moves in fairly easily, and the cornea is fairly accepting of this tissue. All these corneas that you've seen so far, the two cases, were before cross-linking.
More views of externally now, what that looks like. That's just the opening of the actual channel, and then here we're back to pulling that CAIRS tissue so it's even in the channel.
And if it's too long, it can be trimmed with scissors, just pulling out the channel stabilized this tissue. It can be trimmed because I want this just short of the incision, so there's less chance of it coming out of the wound staying open.
Now, this is the one-day post-op for that patient, and if you have a keen eye, it looks beautiful, but there's a few little teeny tiny fibers that got pulled into that area at the time of the post-operative time. Those were removed, and this is a reminder that that tissue, that slit opening, is still open at the one-day post-op. No bandage contact lens is used, but you can see as that is pulled out and cleaned out very nicely. And at 6 months, the same patient in the other eye had CAIRS in both eyes. This looks very stable and is providing a significant effect. We saw a significant change to the refractive error for this particular patient.
Yes, and most of these patients have never been able to see well without contact lenses, and to give them some sort of more functional vision can be very rewarding. It's by no means perfect. As you saw from the topography, it's still highly irregular, but it is another approach that is tissue addition as opposed to subtraction, which is usually what we have to do with topography-guided ablation or even with a transplant.
And I think it's a good reminder, since a lot of keratoconic patients are in sclerals or in glasses, this still means that they probably need to be in sclerals or glasses, but are less dependent on those optical devices to help them see.
Correct. So the best vision is still achieved with scleral lenses, but the benefit of this as opposed to Intacs is it does not affect the fit very much. So fit can still be achieved fairly easily with scleral lenses, and oftentimes if the patient is in scleral lenses beforehand, even after the Intacs, they can use the same scleral lens until their vision has stabilized and the cornea is stabilized for a few months. Again, it might not be a perfect prescription, but still more functional than it would be without it.
Just views of the anterior segment OCT of those nice wedges there where the CAIRS tissue has been placed, and good example of before CAIRS and after CAIRS in the right eye. And you can obviously appreciate this steepening area below the cone where the CAIRS has been placed, but that's trying to provide a more regular curvature to where the actual cone is.
So if they're steepening, it means a relative change in curvature from one area to the next. And if you think of the CAIRS being implanted and flattening and pushing things up, now immediately adjacent to it, this cornea has become relatively steeper. So hence why it looks on the bottom, outside of the CAIRS, that they're steepening. Not concerning, again, normally expected response, and it doesn't mean that this has now become ectatic.
A question I heard recently was, would you ever expect this CAIRS tissue to produce a shadow in somebody's vision or block any of their vision? Would you expect that ever in this?
Shadow, it depends on the pupil size. This goes into 4 millimeters, so does it affect the vision? Yes. We had one patient that we'll discuss as the next case, that his main complaint was he had cross-linking, he had fairly good corrected vision, but he still had intractable ghosting at night. And even though it affects the vision somewhat, it's not as annoying as Intacs, for example, which have a very sharp edge. So all Intacs patients tend to get a lot of glare and halos.
We'll finish up this case before we get to that one, but just another view of what that anterior segment OCT looks like, and then the left eye, since this patient ended up being a bilateral case and both had this procedure done.
And here again, the example of inferior steepening, superior flattening, and then the relative steepening superiorly, and again, this expected peripheral steepening after CAIRS.